If you wake up tired, the obvious assumption is that you slept badly. But here's the twist. Some of the most concerning sleep problems happen when you think you slept fine. You got the hours, you didn't remember waking up, and still, morning feels like you got hit by a truck. So when should you actually worry? Not in a panicky way, in a practical way. A useful rule is this: if morning exhaustion is frequent, predictable, and starts affecting safety, mood, or basic functioning, it deserves a closer look. If you're nodding off while driving, needing caffeine just to feel normal, or feeling unusually irritable and foggy before noon, that's not just a busy season. And if insomnia symptoms show up as a pattern, not a one-off night, that pattern matters more than the worst night. Over the next few minutes, we'll build a simple mental checklist: what's normal, what's a red flag, and what to track so a professional can actually help you instead of guessing. Moving to slide 2. First, let's separate two things people mix together: sleep quantity and sleep quality. Quantity is how long you were in bed. Quality is whether your brain and body actually moved through the stages that restore you. You can get 8 hours of low-quality sleep, fragmented, too light, or disrupted by breathing issues, pain, reflux, temperature, noise, or stress hormones. And the result is the same as sleeping less. You wake up unrefreshed. On the other side, you can get 6.5 hours of solid, consolidated sleep and feel fine. Not ideal long-term for everyone, but it shows why the number alone is not the full story. A practical way to think about it is this: if you consistently wake up exhausted, you're either not getting enough sleep, not getting good sleep, or something medical or psychological is draining your energy regardless of sleep. That's the map. Now we can talk about what makes it worth worrying about, and what's just a normal rough patch. Moving to slide 3. So what counts as constant? A lot of people wait until they're completely falling apart. But you don't need to suffer that long. A common clinical threshold is frequency and duration. If insomnia symptoms happen at least 3 nights a week and last for 3 months, that's considered chronic insomnia. Symptoms can be trouble falling asleep, trouble staying asleep, or waking too early and not being able to get back to sleep. For morning exhaustion, the same idea applies. If you wake up unrefreshed most mornings for weeks, and it's not clearly explained by short sleep, travel, or a temporary stressor, that's a signal. And there's another threshold that matters even more than the calendar: impact. If it's affecting work performance, relationships, driving, or mental health, you don't need to hit the 3-month mark to take it seriously. Think of time and impact like 2 dials. Either one turned up high is enough to justify getting help. Moving to slide 4. Let's get specific about red flags. Not, I'm tired. More like, this could be unsafe or medically meaningful. One big one is sleepiness that breaks through effort. If you're fighting to stay awake in meetings, while reading, or during short drives, that's different from feeling low energy. Another is microsleeps. Those brief unintended seconds where your brain checks out. People often don't notice them until something scares them, like drifting in a lane. Another red flag is breathing-related symptoms at night. Loud snoring, choking or gasping, waking with a dry mouth, morning headaches, or a partner noticing pauses in breathing. Those can point towards sleep-disordered breathing, including obstructive sleep apnea. And then there are systemic signs: unexplained weight change, night sweats, persistent pain, new heart palpitations, or severe mood changes. If any of these show up, the question shifts from how do I sleep better to what's interrupting recovery. Moving to slide 5. Now, let's talk about insomnia patterns, because the pattern often tells you the cause. If you can't fall asleep for a long time, your brain may be in a hyperarousal mode. That can be stress, anxiety, an inconsistent schedule, late caffeine, or just a learned association where bed equals thinking. If you fall asleep fine, but wake up repeatedly, think about fragmentation. Noise, light, temperature, pain, reflux, alcohol use, or breathing issues can do that. Some people also wake because their sleep schedule is misaligned with their natural rhythm. If you wake too early and can't get back to sleep, that can be stress, depression, or circadian rhythm issues. It can also happen when you're undersleeping, and your body is running on adrenaline. What makes it worth worrying about is when the pattern is stable and stubborn. Same problem, same time, week after week. That's usually not random. That's a system doing something predictable. And predictable problems are diagnosable problems. Moving to slide 6. A lot of constant morning exhaustion comes from one boring issue. Your sleep window is too small. People underestimate how often they're running a sleep debt. You go to bed late, wake up early, and you tell yourself you'll catch up on the weekend. Sometimes you do. But often, the weekend sleep shifts your body clock and makes Sunday night worse. Then Monday morning feels brutal. And the cycle repeats. Here's the worry line. If you need an alarm every day, feel like you could sleep 2 more hours, and you feel noticeably better when you're allowed to sleep in, that's a strong hint that you're chronically undersleeping. That's not a moral failure. It's logistics and biology. But it matters because chronic sleep restriction can mimic medical fatigue, brain fog, low motivation, appetite changes, and mood volatility. Before you assume something is wrong with you, check if your schedule is quietly setting you up to fail. Moving to slide 7. Now for the big medical one that people miss for years: obstructive sleep apnea. It's not just snoring. It's repeated partial or complete airway collapse during sleep. That can cause brief arousals you don't remember. Your oxygen can dip. Your nervous system stays on alert. So you wake up feeling like you never powered down. You don't have to fit a stereotype to have it. Body weight can increase risk, but so can anatomy, nasal congestion, alcohol use, and sleeping on your back. Clues include loud snoring, witnessed pauses in breathing, waking up choking, morning headaches, dry mouth, high blood pressure, and daytime sleepiness that feels heavy and uncontrollable. When should you worry? If you have morning exhaustion plus any breathing clues, or you're falling asleep unintentionally, it's worth discussing with a clinician. Sleep apnea is one of those conditions where identifying it can change the whole picture, because the problem is not willpower, it's disrupted physiology. Moving to slide 8. Another category is circadian rhythm issues. That's your internal clock. When it's misaligned, you can do everything right and still feel wrecked in the morning. A classic example is delayed sleep phase. You naturally get sleepy late, maybe 1 or 2 a.m., but your life requires a 7 a.m. wake-up. So you're forcing sleep before your brain is ready. You toss and turn. Then you wake up in the middle of your biological night. Morning exhaustion is almost guaranteed. Shift work can do this too. So can inconsistent sleep timing, heavy evening light exposure, and long weekend sleep-ins. When should you worry? If you feel dramatically better on days you can follow your natural schedule, and dramatically worse when you have to wake early, that points to circadian mismatch. This is also where tracking matters. If you can show a consistent late sleep onset pattern, a clinician can separate clock issues from anxiety or insomnia disorder. Moving to slide 9. Let's zoom in on stress and mental health, because they can create insomnia that feels physical. Stress doesn't just make you think more, it changes your body. Higher arousal, faster heart rate, more cortisol and adrenaline signaling. That can delay sleep onset and make you wake more easily. Anxiety often shows up as difficulty falling asleep because the mind is scanning for problems. Depression can show up as early morning awakening, or as sleeping long hours but still feeling exhausted. And trauma-related hypervigilance can keep sleep light, even when you're technically asleep. When should you worry? If insomnia is paired with persistent low mood, loss of interest, panic symptoms, intrusive thoughts, or a sense of dread that's hard to control, that's not just a sleep issue, it's a whole system issue. And one more point, if you're using sleep as the only measure of your mental state, you may miss the bigger picture. Sleep is often the first thing to break, but it's rarely the only thing affected. Moving to slide 10. Morning exhaustion can also come from medical fatigue that sleep cannot fix by itself. For example, iron deficiency can cause fatigue and restless leg symptoms. Thyroid disorders can shift energy, temperature tolerance, and sleep quality. Blood sugar instability can cause night waking or early waking. Chronic inflammation, infections, and autoimmune conditions can create that heavy, flu-like tiredness. Then there's medication and supplement effects. Some can be stimulating, some sedating, and some can fragment sleep. That's not something to self-diagnose, but it's a reason to bring a full list to a clinician. When should you worry? If exhaustion is new, persistent, and out of proportion to your life, or it comes with symptoms like shortness of breath, chest pain, fainting, severe headaches, or unexplained fever, that's a higher urgency situation. Even without dramatic symptoms, if you've optimized schedule basics and you're still consistently exhausted, it's reasonable to ask whether this is a sleep problem, a medical problem, or both. Moving to slide 11. Let's talk about what you can track, because this is where most appointments go wrong. You say, "I'm tired." The clinician says, "Sleep more," and both of you feel stuck. Instead, track a few high-value signals for 2 weeks. 1. Your sleep window. When you tried to sleep, not just when you got in bed. 2. Estimated sleep onset time. Was it 10 minutes or 90? 3. Number of awakenings you remember. 4. Final wake time. 5. How refreshed you felt within the first hour of waking. Also track caffeine timing, naps, and alcohol use, because those can change sleep architecture, even if you fall asleep quickly. And if you have a wearable, treat it as a rough trend tool, not a diagnosis. The most helpful data is still your pattern. This kind of tracking turns a vague complaint into a clear story. It helps separate insomnia from circadian mismatch, and both from sleep apnea risk. It also makes it easier to test changes without guessing. Moving to slide 12. Now, what does a professional evaluation usually look like? This reduces the fear factor. A clinician will typically ask about your schedule, stress, caffeine, naps, and sleep environment. They'll ask about snoring, choking, restless legs, reflux, pain, and nighttime urination. They may screen for depression and anxiety, because those change the plan. If sleep apnea is suspected, they might suggest a sleep study, either at home or in a lab, depending on your situation. If restless legs is suspected, they might consider iron status. If circadian rhythm issues are likely, they might focus on timing strategies and light exposure patterns. For insomnia itself, the most evidence-based approach is often CBT-I, cognitive behavioral therapy for insomnia. It's structured, it targets the habits and thoughts that keep insomnia going, and it's not the same as generic sleep tips. The main point is this: worry should translate into get assessed, not self-blame, not random supplements. A clear workup saves time. Moving to slide 13. Let's land this with a simple decision framework you can use. Step 1. Check for immediate safety issues. If you're drowsy driving, having microsleeps, or you feel you can't stay awake when you need to, treat that as urgent. Step 2. Look for red flag symptoms. Snoring with gasping, morning headaches, witnessed breathing pauses, chest pain, fainting, severe mood changes. Those are don't wait signals. Step 3. If there are no red flags, look at pattern and impact. Is it at least 3 nights a week? Is it lasting weeks? Is it harming work, relationships, or mental health? Step 4. Run the basics for 2 weeks while tracking. Stable wake time, adequate sleep window, earlier caffeine cutoff, and a wind down that actually reduces stimulation. If you do that and you're still waking exhausted, that's a strong sign it's time to get evaluated. If you want, leave a comment with A or B. A means you struggle more with falling asleep. B means you struggle more with staying asleep. And if you found this useful, subscribe for more clear health explanations without the hype. This information is not a substitute for medical advice. High energy is a biological state, not motivation.